All right, so I'd like to welcome one of our fabulous team members here at the Alzheimer Society. So Dana works within the Alzheimer Society of the Durham Region Mint Memory Clinics, supporting the clinics as the behavioral support nurse. Dana has been with the society for 9.5 years and has been working in the healthcare field for over 13 years. Dana has had a variety of experiences in the healthcare setting, working in hospital, community, and clinic settings. Just realized I'm not sharing my screen. I'm telling everybody it's just one of those days. Anyways, apologize about that. So Dana has a variety of experiences in the healthcare setting, working in hospital, community, and clinic settings. Dana's career has been focused on geriatrics and dementia. Over the years, she has been able to contribute to research opportunities, provide educational leadership to other healthcare professionals, and be an advocate for dementia care. In her spare time, she loves being a mom to her twin boys, being outside in nature, and pursuing professional development opportunities. Once again, we will have a little bit of time at the end for questions. If you do have a question, I do encourage you to please put it in the chat. We'll do our best to get to as many as possible. I also would like to remind everyone to please make sure to keep your microphones on mute just to reduce any background noise as well. So, that being said, I'm going to stop sharing on my end, and Dana, you are free to take it away.
Thank you, Sarah, and welcome everybody. Let me just get things set up here on my end. And Sarah, I'll have you confirm in a second just to make sure that you can see everything. How are we looking?
You are good to go.
Okay, good. So I can't see the chat. So if something comes in and needs to be addressed, just pop on audio and let me know. So thank you so much for that introduction, Sarah. I love being here. I've been at the last couple of these presentations, or these last couple conferences. And I'm so glad that it's virtual because the snow is wild outside. So we have no excuses of having to cancel because we're in the virtual world. So yes, my name is Dana. I'm the behavioral support nurse that works within the Mint Memory Clinics with the Alzheimer's Society of Durham Region. And I am pleased to be presenting today about behavioral changes in dementia care. Um, as Sarah mentioned, there will be some time for some Q&A at the end as well. And I hope that this conversation maybe provides some more information to you as caregivers or as a healthcare professional. I would love to see who we have in the audience. So if you get a moment to just kind of type in who, like, if you're a caregiver or a healthcare professional or just learning, that would be wonderful for me to just kind of look through and after read because I can't look at it right now. But hopefully, I'll be able to give you some information today that will be able to help you on your journey wherever you are at. Okay, so this is just our agenda for today. We're going to be just reviewing a little bit about dementia. We're going to be talking about changes in behaviors in dementia, supporting the caregiver in dementia care, supporting the person living with dementia and their behaviors, some talking about strategies, resources, and wrap up. Sorry, was there a question or just a mic slip?
All good. Just a mic slip.
Okay, sounds good. Okay, so we'll jump into the dementia review. So I'm just going to move my little box here so that I can see properly on my screen. So I always like to provide some information about dementia just because it's really the basis of what we're going to be getting into about the behaviors. And I don't expect the caregivers that I work with to, have a healthcare degree in dementia care or anything, but I just want them to have some general overview and information so that they understand. And then it's easier, I think, when I move along in my consultations to be able to make sure that we can kind of relate to why these behaviors could be happening. So, dementia is an umbrella term for a group of diseases that are associated with loss of memory, changes in personality, and changes in the ability of oneself to complete activities of daily living. Alzheimer's disease is the most common type of dementia. Vascular dementia, Lewy body dementia, frontotemporal dementia, and mixed dementia are several other types of dementia that I see quite frequently in my practice. Now, there's over 100 different types of dementia, and no, I do not know all of them. Dementia is not a single disease. It is a group of symptoms that someone can experience. It's a variety of diseases that affect the brain cells are what causes the dementia. Right now, there is no cure for dementia, and it is a progressive disease. There are medications that can help slow down the disease, but it does not prevent the damage that has already occurred or further damage from occurring in the brain cells. Dementia diagnosis can be compounded or misconstrued with other concerns a person may have, like mental health, medication side effects, vitamin deficiencies, sleep apnea, alcohol and drug use, and endocrine concerns like thyroid or diabetes. And diagnosing dementia can be very complex. It can take time, and there's at times limited access to resources, which can delay supports for the caregivers and the person experiencing the dementia diagnosis. I like to show this slide with the areas of the brain and what the brain controls as a recap to remind just how powerful our brain is. When we start to have deficits in certain areas of our brain, this will, of course, impact how we are presenting with our symptoms. The impact in certain areas of the brain will also explain why a person living with dementia may explain a bit more about how they are presenting. I'll just give you a couple more seconds to kind of look over this just to see. And so the frontal lobe, you can kind of note there that that's a lot of like our judgment and planning and problem solving areas of the brain that control kind of like, when we're driving or making quick decisions. Our cerebellum, that's more over here in the purple side. That's our coordination of voluntary movement, balance, and our equilibrium. I'm not going to go through all of it, but it's there. And if you want the slides, Sarah, can I provide the slides if they want them?
Yeah,
Or
absolutely. We're also recording the session too.
perfect. There we go. Now, these images here are showing you what a healthy, normal brain looks like and what a brain with Alzheimer's disease can look like. You can see the shrinkage in the brain with Alzheimer's disease in that top photo right beside that normal brain. And then in the bottom photo, those bright colors indicate brain activity. And in the normal brain, you can see that there is strong activity across most regions. And then in the mild cognitive impairment brain, you're seeing some reduced brain activity, which would be considered early changes. And then, of course, on the far right there is an Alzheimer's brain, and you can see that there is much more kind of blackened color right in the middle there, indicating significant reduced activity in the brain. We're going to talk about the changes in behaviors in dementia. We're going to look at what and why behavior changes occur, symptoms of the changes in dementia behaviors, and the impact of these behaviors in people living with dementia and their caregivers. So, behaviors in dementia are very common. It is estimated that up to 90% of people living with dementia will experience behavioral changes. Depending on the care provider and their experience in the dementia field, you may hear them mention these following terms: personal expressions, neuropsychiatric behaviors in dementia, responsive behaviors. Now, all these terms mean the same thing, which is behavioral psychological symptoms of dementia, aka BPSD. In a survey completed by the Canadian Clinical Practice Guidelines for Assessing and Managing BPSD, the preferred language is behavioral psychological symptoms of dementia, BPSD, to describe the behavioral changes. Now, BPSD can occur at any stage and is more common in advanced dementia. I much prefer using the acronym BPSD because the whole title of it is very lengthy and a mouthful. So, common BPSD symptoms, I've separated them into three main categories. So, we have mood and emotional, behavioral, and perceptual. And we're going to talk a little bit more about those categories. So, we're going to go into mood and emotional first. And these symptoms could look like anger or aggression. So, like a raised voice or frustration, irritability, being easily frustrated, short-tempered, or having a quick fuse. Agitation, like emotional distress, showing through pacing or fidgeting. Apathy, which is loss of motivation or lack of initiative. Depression-like symptoms, sadness, tearful, withdrawal. Anxiety, excessive worry, fearful, restlessness, mood swings or emotional liability, rapid shifts in emotion, crying one moment and maybe laughing the next. Paranoia, being worried or suspicious about something from an emotional perspective, like infidelity. Feeling disconnected, that feeling of being alone or isolated. And this is the person living with dementia's perspective, even though they may not be actually isolated. In behavioral BPSD symptoms, we are seeing the actions of the person living with dementia. So these could be restlessness and repetitive behavior like calling out, tapping, rummaging, wandering or exit seeking, looking to go home or trying to leave, physical aggression, hitting, pushing, throwing objects, verbal aggression, yelling, swearing, disinhibition or socially inappropriate actions, resistance to care or refusing bathing or dressing or medications. Perceptual BPSD is how the person living with dementia is interpreting and perceiving their reality. So these could be hallucinations, which is seeing or hearing things that are not there, or smelling, I should add that into. Delusions, which could be fixed false beliefs, like thinking someone is stealing from them or, their cat is talking to them. Illusions, misinterpretation of objects like shadows or reflections. That second image is a really great example of one of those. Misidentification is thinking that their home is not their home. It's very similar to the lines of delusions. It could also be like thinking that their spouse is not their spouse. Paranoia, again, they question why their caregiver or others are not seeing or believing them. So, as you can see from the three different categories, there is some overlap with these behavioral symptoms in the categories. So now you might ask yourself, why does BPSD occur? So this slide shows you what could be contributing to BPSD, sorry. So there's pain, medication reactions, side effects, undiagnosed conditions, boredom, loneliness, anxiety, frustration, confusion, feeling homesick or feeling threatened or fearful, depression, fatigue, changes in environment. These can all contribute to those behavioral changes. You could also have someone experiencing the behaviors with more than one contributing factor, which adds to the complexity of supporting these behaviors. So we've talked a little bit about why these behaviors happen and what they look like. So what is the impact of these behaviors? Like, why am I here presenting to you about this? So this slide shows you the most common impacts that BPSD can have on persons living with dementia and their care partners. As you can imagine, someone who is experiencing BPSD, this could be associated with a decreased quality of life for the person living through it and their caregiver supporting. It can naturally increase caregiver burnout, especially if there's not enough support available to the caregiver. In the community settings, there is sometimes more limited support for caregivers at times, and they might feel like they're more in an isolated environment caring for their loved ones. Because of the natural increase in the caregiver burnout, this can result in earlier admission to like a long-term care facility or an assisted living facility. BPSD has also been associated with more rapid cognitive and physical declines, poor mental health outcomes for the person living with dementia and their care partners. A higher mortality rate has also been documented for persons living with dementia that have BPSD. And there's increased costs of care and possible increased healthcare costs that caregivers at times may have to hire extra help for the needs that they're experiencing with the person living with dementia. So this is quite a large impact on just a few dementia behaviors that one could experience on this journey. Without our caregivers, caring for someone living with BPSD would not be possible. When I work with families, the caregivers are also my top priority, along with the person living with dementia. I must ensure the support I provide to them will be translatable to the person living with dementia. I'm also curious if there's anyone in today's group that I've worked with or supported in the past. If there is, hello. So, for management of BPSD, it is not a one size fits all solution. We are all unique individuals coming from different backgrounds and different lives. We must consider thoughtful and tailored approaches to care. We often say in dementia care, just because you know one person that has dementia means you only know one person with dementia. This also applies to caregivers. Caregivers, too, come from many different walks of life. They could be spouses, adult children, younger children, parents, even, and sometimes even a good friend or a neighbor. There is a significant variable to caregivers and the approaches of care that the person living with dementia will be provided. Examples like, does the caregiver have their own healthcare needs? Financially, are they supported with being afforded to not work or have the benefits of being able to financially afford extra help or move their loved one into a assisted living facility? Where do they live? Do they live rurally? Do they live in a suburb? Do they live in a house, a condo? Do they live with other family? What kind of extra supports are available to the caregivers to help them support caring for a person living with dementia? So these are just some variables that need to be considered, and there's going to be more on this in this next slide here. Now, within my role, I won't be able to touch on all the aspects of the holistic model approach for caregivers. However, where I can't support, I can provide connections for the caregiver to receive the support they may require. So, building on my last slide, we must look at the whole person and what encompasses this person. So, a few probing thoughts to think about. So, how would one's cultural, religion, or spiritual connections affect their caregiving, coping, or community? What kind of education opportunities are available to someone living in Durham region versus rural Ontario? What is the access like to get this education or the ability to comprehend the information? What kind of physical health is the caregiver in? Do they have their own complex disease conditions? Do they have social supports available to them? What kind of financial strain or supports do they have available? So, all these aspects are coming together to make almost a complete picture of a caregiver. We must consider the caregiver and their unique situation when we are caring for the person living with dementia. And each person with their own unique background will care for a person living with dementia a little bit differently than the next. The resources and education available to caregivers are there in the community, but what happens if the caregiver cannot be available for these supports due to limited resources to make that happen, like having to work or perhaps they don't drive? What are the available supports to the caregiver and the navigation to access these supports? What is the caregiver's true capacity? So I'm talking about physical capacity, emotional capacity, time capacity. The support must match the caregiver and not overwhelm it. I tell caregivers when I work with them that I am here not to make work for them. I am here to help hopefully reduce the work. Implications of a holistic view, the caregiver well-being impacts the quality of care. Another common phrase I say to caregivers is that you cannot pour from an empty cup. Education is not going to be enough to the caregivers without the emotional support of this journey. And lastly, what are the caregiver needs from us as a healthcare professional and for support? A few things: validation, no judgment, clear information, practical tools are just a couple to name a few. We're going to switch gears and look at how we can support our person living with dementia and the behaviors that they are experiencing. We will be discussing the acceptance of the disease, more in depth of the why, and the strategies to support the behaviors that could or are occurring. So, understanding the dementia diagnosis is one thing, accepting of the disease is another. A lot of caregivers experience ambiguous loss, which, if you're not familiar with, is the type of loss one may experience when they are with somebody that is still very much alive, but grieving the thought of what that person was, or grieving the expectations within a certain relationship with that person. Acceptance of the dementia diagnosis helps the caregiver to be able to support the person living with dementia. You accept the person living with dementia and their experiences as real and valid to their experience. And you are meeting the person where they are in their dementia journey, not where we expect them to be or you expect them to be. Acceptance is not giving up or losing hope. It's adjusting caregivers' expectations and care to support the person living with dementia. To add to the previous slide and discussion of why is behaviors happening, we already covered the main reasons, but this slide builds on the additional factors that contribute to why behaviors in dementia can happen. There could certainly be physical aspects to why the behavior is occurring. So pain, contributing comorbidities, sensory loss. In dementia care, there are the 5 Ds of dementia, which are delirium, disease, drugs, discomfort, and disability. And this may also overlap some of the physical contributions too. We need to look for fluctuations in cognition, alertness, nutrition, hydration, elimination, mobility, and sensory impairments. And I do have a short video to show you just in regards to the difference between delirium and dementia. That's another aspect that I do educate quite a bit on. It's very important to consider if someone's having fluctuations or significant disease progression with their dementia, that delirium has been ruled out or considered. So let's try out this video here. So Sarah, if you could just, oh, sorry, I'm gonna have to, I just want to confirm that the audio will be working.
Watch
the cheese does to your waistline. You can hear it?
I can hear it. It's just also just showing your PowerPoint slide and notes, just letting you know.
Okay, how do I do that? Hold on. Let me see here. Share. Okay, let me try this. It's a cheese ad, I guess.
It looks good. Are you able to make it full screen as well?
Yes. Okay, you can see it?
You're all good.
You can hear it?
You're
Okay.
I can't hear anything, Dana. I'm sorry.
Okay, 1 second. You can't hear it.
Are you able to stop sharing and then reshare just to make sure the audio is still enabled? Because I know sometimes when you stop share and reshare, it sometimes does that.
Okay, let's try that. Can you hear it?
I have nothing. Sorry.
Okay. Nope, that's okay. Let me just try one more time. If it doesn't work, that's okay. I can always put the link in the chat box. Let me just see here if there's an option on the computer audio, share sound.
I say when you
Oh,
share your screen on the right side, does it say
I think I got it.
Coherence.
all
Bear in
good?
mind that this can be associated with hyperactivity as well as hypoactivity. So what is the difference between delirium and dementia? The mnemonic we're going to use is OCD-CAMPS. The O stands for the onset, which is typically rapid in delirium, within hours to days, while in dementia it's over months and years. C is for the course. Delirium is often fluctuating, meaning the patient may be quite settled at some points and more agitated in others. Typically, there's the sundowning phenomenon, where patients with delirium become more agitated towards the evening. In hypoactive delirium, this is harder to appreciate, however. Dementia, on the other hand, gets progressively worse. Next, we have D for duration, which in delirium is mostly days to weeks and is reversible, although it can last months in causes such as liver failure. In dementia, the duration is again much longer, months or years, and in this case is irreversible. The second C is for consciousness, which is usually altered in delirium, while in dementia they can be clear, although of course this can be affected greatly in dementia too. A is for attention, which again can be altered in both dementia and delirium, but in delirium there is a significant impairment typically present, while in dementia the attention may be somewhat normal, given that overall dementia is mostly associated to memory loss, while delirium heavily features a lack of concentration and inattention. M is for memory. In delirium, the immediate recall is usually impaired, while longer-term memory may be quite good. In dementia, however, the immediate recall is often normal. P is for psychomotor changes, which, as we mentioned in delirium, can be hyperactive or hypoactive, whereas in dementia, psychomotor disturbances are not usually present. Finally, we have the S for sleep-wake cycle, which again can be altered in both, but is often significantly different in delirium. Often a complete reversal of the sleep-wake cycle is present.
Okay, I'm going to just stop that share and I'm going to go back to my slideshow here. Oh, hold on. Okay, are we back in the slideshow?
Just giving it a second to load. You're all good.
Okay, perfect. So the synopsis is, if we suspect a delirium, it is a medical injury or medical emergency, sorry. And it needs intervention. So either the ED department, urgent care, or your doctor, depending on what's going on. But of course, if there's changes suddenly with the cognition, it could make behaviors worse. All right. So to support the person living with dementia, we need to try and see first again the why behind the behavior. The PIECES framework is a great tool for healthcare professionals to help find the why. PIECES is an acronym that stands for physical, intellectual, emotional, capabilities, environment, and sensory. What is the impact? So not all behaviors are going to require interventions or support. We help assess this by completing different questionnaires, interviewing the caregiver, or if able to do so, observing the behaviors that are occurring. We need to identify any triggers for the behaviors. And what are the current supports for the person living with dementia? Are they involved with the Alzheimer's Society, BSO? Do they live in a facility? What is the relationship like with their family? This is just that PIECES framework. It goes into a little bit more detail about the acronym. And these are different questionnaires that healthcare professionals may use to help support the person living with dementia and their care partners. So it depends on the clinical setting and what's required that we would administer different ones. At the Mint Clinic, we do use actually all of these are three different ones on this screen. We have the MPIQ, which is designed to assess for 12 domains of a behavior, and it determines the severity and distress of the behavior, and this is done with the caregiver. We do a Cornell depression scale. This is actually done with the person living with dementia and their care partner, as well as the Zarit caregiver burden scale. But there's also some other questionnaires and assessment forms that it does exist out there in the healthcare world. There is a dementia observation scale. There's the frontal battery index that I've also used in the past. So when we are supporting a person living with dementia experiencing behaviors, it is important to remember that all behavior has meaning. We should help the person by focusing on the positive things for the person and their experience. Remember the person beyond the disease. Remember to never take it personally and build on the person's strengths and abilities. I also love this visual of the iceberg because it just reminds us that we only see like the top portion of sometimes of a situation, but if you really look beneath the surface, you might see a lot more. To help support the person living with dementia, I created this simple Venn diagram to show caregivers the difference between supporting a person living with dementia and their reality versus our current reality. It serves to remind caregivers that what they are experiencing may differ from the person living with dementia. At times during the dementia journey, and depending on the stage of the dementia, there will be reality crossovers. I also like to remind caregivers that when we accept and understand the diagnosis, we will be anticipating the caregivers to join the person living with dementia's reality versus expecting that person to come into our reality. I felt that this was also helpful to support how strategies are important. This is the cycle of a delusion of delusions, where understanding and acceptance of dementia and behaviors can help impact the caregiver to support, once again, the person living with dementia experiencing BPSD. So we have at the very top there, misinterpretation of reality. The dementia brain misreads environmental cues. So example, wakes in the middle of the night, here's a car outside. Jump down to false perception and assumption. The person interprets the sound as a possible threat. So now they believe someone is going to break into their home. Delusional belief formation is the brain connects the false perception into a story that makes sense to them. They believe they are unsafe and that someone is inside of their home. Then we have the emotional response or the distress. The person experiences genuine fear and anxiety due to this belief. They express worry, calls for help, appears fearful or agitated. And then this cycle can repeat with new stimuli. So at all points of this cycle, we can help to identify the triggers and intervene appropriately. And then we're going to move into what those interventions would and could look like. So when we consider strategies to support someone living with dementia experiencing behavioral changes, the best practice guidelines for behaviors in dementia care are to explore and consider non-pharmacological strategies first. This is where my role comes in to help educate and support the caregivers to support the person living with dementia experiencing the behaviors. Non-pharmacological strategies are using strategies that are not based out of pharmacological options. So this could be music therapy, reminiscence therapy, animal therapy, Montessori-based activities. Number two, pharmacological approaches sometimes need to be considered for really distressing behaviors or behaviors that are affecting the person's living with dementia's quality of life, the caregiver's quality of life, or if safety is a concern. Sometimes some behaviors just cannot be managed with non-pharmacological strategies, and this approach must be considered. Your healthcare team would choose the most appropriate medications to help support the person living with dementia. And sometimes physicians will prescribe antidepressants, anti-anxiety, antipsychotics to help with these behaviors. The physicians will aim to start slow and low, and they want to use the least riskiest medication side effect profile for that specific person. At times, we have to use a dual approach of these strategies, which is a combination of non-pharm and pharm. Sorry. So these are just some of the images of the non-pharmacological strategies that I educate and support caregivers. So there's animal therapy, doll therapy, offering a warm beverage or a snack, activities to keep busy, walking, working out, music therapy, or listening to music. I do have another really short video, but I'm going to skip it just so that we have a little bit more time for Q&A potentially. It's a very short video. It just, it's talking about animal therapy, but once again, I can include it in the chat. Along with the activities that help to provide support and meaning to the person living with dementia, there are several other options for non-pharmacological strategies that can help support the person living with dementia. So educating the caregivers about communication strategies, and I included a little snippet on this slide of our handouts from the society with communication strategies, like not arguing, avoiding confrontation, avoiding words like, don't you remember? Providing simple explanations, agreeing with the person living with dementia, and having patience and understanding. Therapeutic reasoning is where I teach caregivers how to use this technique to support the person living with dementia in their reality, and you use responses that make sense to the person with dementia. Validation techniques and the support that this can provide to a person living with dementia, along with redirection, de-escalation, and reality orientation strategies. This image is just showing how the stages of behavioral escalation can occur. I try and teach caregivers, how to avoid that outburst stage by learning to recognize the prior stages that could be targeted to avoid that outburst. And so we want to learn what the triggers are and what the signs of the behavioral changes are to try and curb that from happening. So this is just building on the information previously provided about the pharmacological options. This would always be a discussion with the physician, and they would decide the most appropriate medication for each individual person. I also listed just like the common types of medications in those classifications that I see in my practice. And then these are some behaviors that we see in dementia care that are not appropriate to be used for medication. So, wandering, inappropriate urination or defecation, hiding or hoarding behaviors, pushing co residents and mobility aids, removal of restraints. Um, Medications could help with being able to easily redirect the person if they were, becoming agitated, but they wouldn't necessarily stop the behaviors. But we'd also want to try and put in strategies in place to try and prevent these behaviors as much as possible. So to recap for supporting the person living with dementia, so BPSD is not a one size fits all solution. We want to find out the why of the behavior. We can only control our responses and our own behaviors. Each individual will have their own unique approach. Try and have a toolbox of strategies to use. Ensure you're taking care of yourself as a caregiver and obtain and use the support available to you. These are some resources that I just thought would be helpful. I really enjoy sharing the Teepa Snow videos on YouTube. She's also got some shorts for some quick learning for caregivers. And these are just some of the information about what the Alzheimer's Society of Durham Region offers to help support caregivers and persons living with dementia. So I wanted to make sure we got to some time for some Q&A because I think my time's up at 11:15. So please ask away if you have any questions.
Wonderful. Thank you so much, Dana. A wonderful presentation. Yes, we do have a couple more minutes. We are going until 11:15. So if you do have any questions for Dana, please pop them into the chat and I can help facilitate them before we jump into our next topic. There was one in the chat that I saw earlier and says, I heard that the Ontario caregivers are doing a mentor program to help the caregiver's journey. Dana, I'm not sure if you have anything on that.
Sorry, it's in the chat.
Yes. This came
Um,
around 10:50.
okay, yes. So there is, I haven't heard of the mentor program. That sounds fabulous though, but I do know that the Ontario caregiver, I can't remember the actual name, but I do recommend that website and the link to their supports because they have a lot of great resources for caregivers. So at this time, I'm not familiar with the mentor program. I would recommend going to their website to check it out because they probably have up-to-date information on that. I do agree in that second point of your comment. The hard part is accepting the diagnosis. So, yes, that's why I talk a lot about acceptance and the diagnosis together when I work with caregivers.
Perfect. Thank you, Dana. There's another one to that says just to highlight the symptoms of each type of dementia can be different. It is necessary to show that for new caregivers as well. So thank you for popping that in the chat. We have a new one that just popped in. It says you mentioned that Montessori type activities can be helpful. What would you say a key activity qualities might that include?
Yeah, so great question. So these can be really simple. And I often tell caregivers, like, you don't have to worry about spending extra money. You probably already have these items, or you could get the items at the dollar store or Value Village, whatnot. But folding like washcloths or folding towels, like that can be really helpful. I have actually just recommended to a retirement home a week ago just to keep a stack of like little hand towels at their nurse's station to give to one of the residents that we're having because he wants to be helpful. So I love that one because it's very easy to implement. Sorting things like this could be anything like sorting cutlery, sorting coins, getting them to organize papers or mail, anything that you kind of have laying around. Sometimes it just takes like a conversation to kind of get the thoughts and the ideas kind of rolling. I also have a lending program that I offer through when I'm with my clients through the memory clinic. And so I've also included some items that are Montessori inspired. So, screwing in like little like bolts onto screws, putting together like little pieces to create it like a 3D image. Now, obviously, those items you might not just have laying around your house, but even like big pieces of puzzles to do together, things like that. So there's a plethora of resources. If you type it into, like, for example, the Teepa Snow on YouTube, like there's some great ideas. And like I said, you don't generally need to spend any money, which is a bonus. I hope that helps to answer some of it.
Wonderful. Thank you, Dana. I see two more hands being raised for a verbal question. We'll try and do both. If not, Dina, if you're also comfortable, if you want to put your contact info in the chat, we can follow up afterwards. I saw Renee's hand up first. Renee, if you're able to unmute yourself and ask your question verbally.
Hey, thank you. Yes, Dana, thank you so much. I just wondered, my mom was diagnosed with dementia back in 2016. She probably had it maybe 5 years even before then. It's interesting to listen now and see all the different stages she's been through since then. So she's in long-term care. She's yeah, she found great help with having a doll at different times in music therapy, and especially because she loved the kitchen, loved folding things. So that really is helpful. I'm just wondering now, I guess I would consider she's probably in the late stage dementia. And I don't really hear much about that, like what to expect in that regard. I guess I would call her nonverbal. She might get out a line or two randomly, but I guess just what to expect in that regard, or what are some of the things you might see at that time?
Yeah, so that's a it, it might take me a while to answer that question. So I would love to maybe send you an email or we can connect via telephone just so I can give you more information and I can give you resources. So as somebody does progress in the disease, yes, typically they might become nonverbal or unable to, communicate effectively. Um, maybe they lose the ability to feed themselves or, they're not able to walk anymore. I'm not sure if your mom is like that. You are correct in the sense that, like, yes, she was diagnosed in, I think you said 2016, but she probably did have it for several years prior to that diagnosis. That's just kind of how the disease and the diagnosis works. So, at this point, like if she's still able to do things, you didn't like mention if there's any behaviors or anything. So I'm assuming there's not, but just that engagement of activities, perhaps. She can still certainly, enjoy listening to music, or we can cater the activities to meet her needs. So if she's not able to stand to fold things, could you give her something to fold? Or if you're in the Whitby area, we have like volunteers who make like fidget blankets or fiddle muffs that we can give out to people as well, to help support, just to kind of give that sensory, looking at visual stimuli like photos or places that maybe she's been to before, engaging with the doll, engaging with the even a robotic animal as well if she enjoys that. But as for like the specifics of like the advancing of like the difference between the middle and late stages, I can certainly give you a lot more information kind of offline if you're okay with that.
Yes, that would be great. Thank you. Thank you very
No
much.
problem. I'll put my contact information in the chat, okay?
Yes.
Perfect. Thank you so